Good morning, and thank you for joining us on this Cupron Medical Textile WebEx, reviewing information previously disclosed at APIC National 2018. And the WebEx is a practical innovation for infection prevention. Today we're going to be focusing on the role of the environment in infection transmission and looking at how linens can act as a vector to assist in the spread of pathogenic organisms and also hospital-acquired infections. After that, we're going to look a little bit about Cupron's proprietary copper-based technology, as well as explain why copper is such an excellent antimicrobial and the choice of active ingredient in Cupron Medical Textiles. From that, we'll review some of the Cupron portfolio of trials, including the initial Sentara Healthcare trials, before handing over to Jackie Butler, the co-presenter on today's WebEx, to review more history about Sentara Healthcare as a system, as well as the most recent data from their expanded deployment of Cupron Medical Textiles to all beds and facilities within the Sentara Healthcare system. After that, we'll be looking at operational information relating to handling, cleaning and laundering of the Cupron Medical Textiles, as well as a short video presentation from Ochsner Healthcare System about their selection process for why they deployed Cupron Medical Textiles, and from their laundry partner Crown Laundry as to their handling and choice of the linens. Again, another innovative healthcare system like Sentara Healthcare System and their decision-making process around using Cupron Medical Textile. We will then have a short question and answer session available at the end, and if you'd like to submit a question to either of today's presenters, please feel free to do so. So it's my distinct pleasure to introduce Jackie Butler, today's co-presenter. She is the Corporate Director of Infection Prevention and Control for Sentara Healthcare System. Jackie is certified in infection control and epidemiology through the CBIC certification and has been an active APIC member since the 1980s and has been in the field for over 30 years. Jackie has been a very active local chapter figure for APIC Virginia and the Tidewater infection community, as well as serving on the CBIC board for 2 3-year terms. Jackie has been recognized and a recipient of the Virginia APIC Award for Distinguished Service 3 times and has been a key figure in leading Sentara's adoption of the Cupron technology. We're delighted she could join us this morning to talk to you a little bit about Sentara's trial portfolio and decision. My name is Alistair Monk. I am a VP for Medical Products at Cupron, and my day-to-day roles really focus around the clinical, regulatory, and scientific portfolio management for Cupron. So moving on to the sort of first slide about the environment, and this is a recent slide based upon a very recently published study published in 2018, earlier in this year, and it really looked at the increased incidence for the next patient coming into a terminally cleaned and turned over room. Odds of 5 to 6 times more likely to have an infection in that room that has been terminally cleaned and disinfected if the previous patient had an infection, or if a roommate of that patient had an infection transmitted to an incoming patient in a newly cleaned room. We think this is a very key point because it really speaks to the role of the environment, mostly due to the transmission pathways from a previously infected patient or roommate transferring through the environment, even though that environment has been cleaned and turned over, but the next patient has a 5 to 6 times more likely to acquire the same infection. Environment, and why is it such a key factor in the transmission of these pathogens from the environment? So we've also looked at all of the literature and developed this infographic. And this infographic really, to us, speaks based on what we know from the literature as to what are the most touched and what are the most contaminated surfaces, as to where we can find these organisms, and then where healthcare workers and other people have interactions with those surfaces. So we've gone ahead and highlighted, obviously, the textiles being the most contaminated for MRSA and C. difficile and the most touched surfaces in the room. And so the color actually corresponds. The darker the color, obviously the more touched and more contaminated, and the lighter colors obviously are lower amounts of touch or contamination. So really focusing in on the direct area around the patient, we can see the patient gown, bed linens are the most touched and most contaminated, as I say. But as we go a little bit further out, you start seeing that the bed rails and overbed table are also contaminated. And the further we get from the patient, the lighter the amount of contamination. And a lot of this, I think, speaks to the linens themselves being things that can transfer organisms into the environment. So contaminated linens during bed making processes or during change of actual patient gowns or the bed itself can therefore transmit into the rest of the environment and pass that contamination along. To that sort of point, we've developed a very complicated graphic that we will be having pop quizzes on at the end for everybody to see who's still with us. But we've really developed this flow-through infographic to look at what is the pathway that linens can actually act as a vector to get organisms from patients who are infected or contaminated into susceptible patients to then increase their risk of a hospital-acquired infection. So we know that from the literature, making the bed and changing the patient's gowns or even their pajamas results in anywhere from 10 to 26 times more contamination in the air, which obviously can then settle out onto these other surfaces. And then looking at the sort of the colored graphic on the right-hand side of the screen, organisms that can be transmitted from patients obviously end up on their textiles, as we know from the previous slide. Those surfaces, the textile surfaces, are a fantastic substrate for organisms to grow and thrive upon, just because the very close relationship to the body, great microclimate, and some of the organic material helps these organisms to grow and thrive on the textiles. And then bed making and other interactions can transmit those into other surfaces, and then the orange boxes show how those organisms can then be transmitted to a susceptible patient, either via aerosolization or via healthcare worker hands or other contact to then deliver these pathogens to a susceptible patient. And I think the point from this slide really is that the linens themselves can act as a vector to not only carry organisms to susceptible patients, but also then to transfer those organisms back to other susceptible patients in the arena. So I think at this point, just taking a quick pause, what we've looked at is, we've looked at the environment and how the environment can transmit pathogens to next incoming patients who might be susceptible, therefore increasing their risks of a hospital-acquired infection. We've also then looked at the organisms themselves in terms of where are the most touched and most contaminated surfaces. And now I think we've developed a chain of evidence to show how we can get organisms from textiles into other environmental surfaces and other patients. And so a key question here for the sort of next point of this is how long can things survive on these organisms, on these textiles, I should say. So this is a publication that came out a while ago. Came out in 2000, but it's a really key data point. And I know there's a lot of information on this slide, and we're going to walk through it. But the authors of this paper took organisms that are commonly found in hospital-acquired infections, so Staphylococci and Enterococci, both resistant forms, antibiotic-resistant forms, and susceptible forms, and then they took a number of different substrates of common textile materials, so cotton-based products, terry products, which would be towels and washcloths, blended products of cotton and polyester, and then also more of the sort of man-made fibers, polyester and polyethylene, and they looked at how long these bacterial organisms could live on those textiles, thrive and grow, and still be viable. And so what we see is that on the low end, we can certainly see survival for a number of days, but on the high end, some of these organisms can survive for up to greater than 90 days, growing, surviving, and thriving, and still being active and viable on these textile substrates. So I think it shows a lot of the data we've talked about as to why textiles are such a good substrate to not only transmit organisms to susceptible patients via healthcare workers or other areas, but also then once you're handling those textiles, those organisms are viable and can be transmitted to other surfaces, which speaks really to why one has to have great guidelines for handling contaminated textiles post-patient use. Based on all of the data that we've just talked about, the sort of flow from why the environment is so important to what are the most contaminated surfaces, the textiles closest to the patient, and how long things can survive and grow on textiles as they're such a great vector for transmitting organisms and being disseminated into the environment. We developed a hypothesis that I'm delighted to talk a little bit about the data that supports some of this now, after working with such a great partner as Sentara Healthcare to clinically validate these points. But this was our hypothesis as we started that journey, which is because patients are the source of the contamination, that then can lead to other environmental surfaces as well as textiles being contaminated. If we then put
them on the drag
self-sanitized textiles around the patient, we can then lower the bioburden, which will interrupt the colonization and transmission of those pathogens, and then ultimately could lower hospital-acquired infection rates. And so this has been a driving hypothesis for Cupron that we're delighted to have partnered with Centera Healthcare to address. And so really, Cupron's technology has been a key player in answering this. And so that leads us to the question of what is the Cupron technology? The Cupron technology is an embedded copper technology that is inserted at the time of manufacture and is physically embedded into the fibers that make up the textile products. Therefore, it's not a topical application, it doesn't wear off, and it doesn't wash off. And it also gives a unique color, which we'll touch upon later, which is a key attribute in some of the positive interactions with healthcare workers and staff. But this slide really shows that process, which is taking the copper metal in the top left-hand corner. Cupron specifies specific attributes, physical characteristics around copper particles in terms of size and dimension and other attributes that go then to make a plastic pellet on the top right picture, which then gets extruded to make yarn there in the bottom left-hand corner, and that yarn is then turned into fiber, which then makes the textiles, and those are the Cupron medical textiles that are being shown in that bottom right-hand image, real-world use of the textiles being used by patients. So this just goes to show you that as I say, the copper is embedded right upstream at the time of manufacture, therefore not washing off and not wearing off. To that end, we've then obviously assessed the efficacy of our product over a number of launderings, commercial launderings, and I think it's important here to take a step back and say we assessed the Cupron linens by using a real-world industrial laundering partner to cycle them through the standard conditions, wash temperatures, chemicals, so that we could then pull out samples every 10 launderings and go in and make certain that the product was still efficacious. And what we see is that we picked two examples here, a washcloth and a knit sheet, and we ran them against three organisms that commonly are related to hospital-acquired infections, so Klebsiella, Enterobacter and Staphylococcus aureus. And so we looked at 50 washings and 100 washings, and we see no loss of efficacy across those time frames due to the embedded nature of the Cupron technology. And that was a test that was performed. As I say, with an institutional laundry partner using real-world conditions and applications. And so one of the other interesting data points that has come out from our use across the Centera Healthcare system as part of our expansion to all 2,500 beds now is having the data to say that the Cupron technology and the Cupron products are actually more durable than standard linens. And so I would call your attention to the washcloth that we've just talked about on the previous slide, as well as the knitted sheet. And so we see the washcloth is traditionally about 7 laundering cycles, so 7 servings on a white product, but the Cupron product actually goes up to 15 due in nature to that unique color that I talked about earlier. Also, because of the nature of the construction that is used, it just provides a much more durable aspect. So the other product would be the knitted sheet, which is in there as a fitted sheet, and that gives you, again, about 27 traditional servings on the white product, and we're up to around the 47. Overall, Cupron products get around an 80% more servings, more turns in a laundry environment than traditional white products. And so, the question that we get, which is an excellent question, is why copper? Why would one use copper as an antimicrobial agent? And it's really because it's very, very effective. It has broad spectrum activity across both bacteria, fungus, and the sporicidal impact. It's been shown to be a continuously active antimicrobial agent, and now has been published. There are multiple peer-reviewed published trials in the scientific literature that talk not only about its ability to reduce bioburden, the amount of organisms that are on surfaces, so pre- and post-test. There are 10 studies that have been published that show copper surfaces, when compared to non-copper surfaces, can reduce
bioburden levels anywhere from 17 to 83%. But more importantly, I think, has been shown, there are now 6 studies that show that when the copper products are used, there is a reduction in the patient acquisition rates of hospital-acquired infections. And so of these 6 studies, we're delighted to say that the publications, 5 of them are based around the Cupron technology, and of those, 3 are directly related and as a result of the excellent work that we perform with Sentara Healthcare System. And so leading on from why copper is, how does copper work? Well, copper attacks microorganisms via multiple modes of action. And so one of the reasons that this is important is there isn't a single mode of action like an antibiotic or other products. So there isn't a single kill mechanism to become resistant to. There's multiple modes of activity. And so as we go around the different modes of activity like a clock starting in the top right-hand corner, using via oxidation, copper ions can directly weaken the cell wall by pulling out electrons which puncture holes in the membranes. There's also a physical nature to this, which is as the microorganisms land on the copper and those electrons are pulled out, these holes are punched, leading to cell death. If for whatever reason the microorganisms don't come in direct contact, then copper ions released by the technology can then also disrupt the transmembrane potential, which is a charge, which then again punctures holes, allowing nutrients and water to flow out, leading to cell death. Copper ions, once they also enter the cell via these holes or these things that have been punched in the membrane, then attack the energy production of the cell, so disrupts metabolism, so the cell can no longer generate energy. It binds to DNA, which prevents the cell replicating and changing, and also breaks down RNA, which really shuts down the ability to make any proteins or anything else. So it could be one or all of these mechanisms in play at any moment in time, which is why these multiple modes of action have the ability to really be highly effective and broad spectrum, as we talked about. And so based on all of the data we've talked about, which is, the role of the environment and why it's so key, we've also talked about, having a look at what the Cupron copper technology is, the physically embedded nature of how we put copper compounds into products, and now why copper and the publications that relate to the outcome-based data. I'm just going to walk you through some of the initial trials that we have before I hand over the presentation to Jackie Butler to talk a little bit more about the Sentara Healthcare System and to put into context the trial publications that we have. So starting sort of at what we feel is one of the lower levels of data quality is bioburden data, which is the amount of products or the amount of organisms that are on a product. So Cupron medical textiles have been shown to statistically significantly reduce bioburden counts pre and post patient use. So both gram-positive and gram-negative bacteria, we can show a statistically significant reduction in the amount of those bacteria on the sheets pre and post use, which is a key finding to take our laboratory data, our antimicrobial efficacy post laundering, and then to say what does that mean when we actually use it around patients is, well, we're still killing those organisms in a real world patient setting, which fits into the hypothesis of being able to reduce bioburden to therefore reduce HAI rate. So a key finding for us, which then led us to look at this is a summary, really, of the outcome data that we have, and so we're going to dive into this in a little more detail. But what you can see of the 4 studies that are up is they are all published or accepted in peer-reviewed publications. And what we're starting to show is that we've been increasing the size and scale of these studies thanks to our relationship with Sentara, being able to look at Lee Towers as a fundamental underpinning of our outcome-based data, and show statistically significant drops in infections. So this is just a snapshot in time. We're going to come back to this later on, but it's really just to show the variety of data that we have from linens only, looking at C. diff and MDRO-HI reductions. So Raouf's study was one of our first pilot studies. It was a proof of concept study that showed a 35-bed reduction in a variety of HAI-based outcomes. It was a 6-month study and overall showed a 24% reduction in HAIs. And so it was a great proof of concept because it was copper linens and patient pajamas and underpads that formed the basis of this study, so a linen-only study, but validated really our hypothesis that by replacing the linens, we can show a 24% reduction in HAI rates, which was statistically significant. And then based on the fact that we reduced HAI rates, we can also show a reduction in antibiotic days, the number of days that people have had to have antibiotics dispensed, and then overall a 20% reduction in care costs due to the reduction in infections, which includes antibiotics, disposables, labor, and everything else. So this was our proof of concept trial, as I say, that then led us into a more rigorous trial design, which was the Herzog trial. And the Herzog trial is more rigorous because we took then 2 wards of 35 beds, again, just using the linens and the patient apara, but what we managed to do was do a double-blind crossover trial. And in a double-blind crossover trial, it's a blinded study because we took 2 products. So we took a Cupron medical textile product and we took a standard white linen. They were both dyed so that you couldn't tell the difference between them. That's the blinding, and nobody knew apart from to the end of the study when we unblinded it, but nobody knew which linen was which until the very end, which allowed us to mask any other ongoing events. So it was a 7-month trial, and we were really looking at when physicians determined an infection was present and therefore had to initiate antibiotic treatment. And so overall, what we were able to show in this double-blind crossover trial is a 29% reduction in these events where physicians determined an infection was present, statistically significant, and so therefore, again, a reduction in antibiotic days, the number of days that patients are on antibiotics, and a 27% reduction in overall in the amount of antibiotics that have been dispensed into this population. So all of these studies then led us, and based on these studies, we were able to then partner with Sentara Healthcare to look at bringing some of this data into a US-based healthcare system in order to really put this into context. And so this led us into the Sentara Lee studies, and these were the largest trials ever conducted at the time of the products. We've actually been able to run larger trials with Sentara, but at the time these were the largest ever. So we were, because of the nature of Sentara Lee, one tower, one side of that image, one wing was being knocked down and replaced. So we were able to put in Cupron linens, but we were also, because of the flexibility of the technology, being able to put into a range of other substrates, we were able to put in, with a partner company, EOS Hard Surfaces, embedded hard surfaces, bed rails and overhead tray tables. So we did a 10-month comparison period of this one side of the wing that was brand new with all the copper products in, compared to an unchanged wing on the other side. So during this trial, we were able to show statistically significant drops in C. diff and MDRO rates, about an 83% reduction in C. diff and 78% reduction in C. diff or MDRO rates. And so these results were very, at the time, were very, very strong. Now, obviously, because we couldn't quantify what the impact of a brand new building was compared to the unchanged side, we searched and were unable to find any data points that told us about this. Because of the fact that Sentara Lee, as we found out subsequently, due to the drive within Sentara to maintain their excellent patient safety and quality, they were undergoing a unique certification process, the first of its kind, a DMV MRI certification, which again, we couldn't quantify any changes in processes, as well as the fact that because it was an operational study to some degree, we couldn't interfere with patient population movements. We then wanted to go back and say that these results were so strong, but they just needed additional deployment and assessment. So Sentara decided to then use the other side of the wing, which leads us to the year 2 study, we call it, which is now Sentara Lee, both sides, both wings have been deployed, and using data warehousing, this study was then able to address the new build phenomenon as well as the concurrent DMV MRI certification by picking 2 other Sentara facilities that within the same system have the same practices. And so we were able to take the 2 other facilities as comparative in order to compare and contrast what the rates were. So now at Lee we have the copper linens as well as the hard surfaces, the overhead tray tables, bed rails, and horizontal services produced by our partner EOS Hard Surfaces. This was an 11-month performance period, so very large patient days, almost 80,000 patient days again. And so we see a 25% reduction in C. diff and a 28% reduction in C. diff or MDRO rates. And so these other comparative facilities at the same time were chosen because they were able to quantify what the impact of new build was. So one of the facilities that we chose, which was the Princess Anne facility, had been newly built within the last 3 to 5 years, but had not undergone the DNV MRI and had not had any copper products, Cupron products placed into it. So that is therefore a new build only assessment tool. We then were fortunate enough to be able to look at Virginia Beach, which was an older facility, so it wasn't a new build, but had undergone DNV MRI and had not had copper products put into it, which gives us this nice comparison. So at a time of Centera Lee, whilst the results are dropping, at these 2 other facilities that were specifically added to this data set in order to address some of those initial confounders, we can see that the rates actually increased in their C. diff and or MDRO rates at a time when Centera Lee continues to go down. And really this study was then resulted in system-wide deployment across Centera Healthcare System, across all 12 hospitals and 2,400 beds. And so this partnership with Centera has now led to this great data set and this enhanced deployment of the products across the Centera Healthcare System. It gives me great pleasure to have Jackie now talk to you a little bit about Centera Healthcare and then reveal some of these results. So I'll turn it over to Jackie at this point.
Thank you, Dr. Monk. I appreciate that. If we'll go to the next slide, we'll go ahead and get started a little bit about Centera Healthcare. Centera Healthcare has over now a 128-year not-for-profit mission to it. It consists of 12 hospitals or 2,581 beds, and our system has doubled just in the last 11 years. We have every type of hospital that you can think about, everything from a level 1 trauma center that has over 500 beds to it, as well as a 125-bed heart hospital on its campus, to a 145-bed community hospital. So we range in bed size and capacity for 12 different hospitals. In 2012, the Centera system made the decision to leave Joint Commission accreditation and form a relationship with DNV and the NIHO accreditation system. And we began that in 2012, and all 12 of our hospitals have undergone the accreditation system, and we are now considered a NIHO accredited system and no longer use Joint Commission at all. During that time period, 2 of our facilities stepped forward and challenged the DMV MIR accreditation or certification system as well. And MIR stands for Managing Infection Risk. It's a higher standard, a special separate standard for infection prevention to attain based on risk management or risk-based standards. Both of those hospitals did attain certification in DMV MIR, and as Dr. Monk said, they were the first 2 hospitals in the world to be able to be certified as DMV MIR. We now have 1 other facility that is beginning the process for DMV MIR certification as well. Everything we learned from the DMV MIR standards and the certification, we do integrate throughout the other hospitals. So it should be a little bit easier for the other hospitals to attain that certification than the hard work that Centera Lee and Centera Virginia Beach put in. We have over 3,800 physicians on staff. 7 of our hospitals are magnet hospitals, and we have 2 more that are in the process of going to for magnet status. We have over 300 sites of care and 12 long-term care assisted living centers or PACE program. A very diverse group of healthcare management. As you can see, we kind of take the holistic approach from that list that's there, and Centera looks at the big picture of healthcare. We look at the physical, mental, emotional health, as well as taking care of social factors into consideration. So it's a very holistic overall approach to healthcare. Next slide. Centera Healthcare has a very basic but very important mission, and that's that we improve healthcare every day. Our values are to serve our people and to provide quality, safety, service, and integrity to the highest standards. Our guiding principles are that we value the health and the lifelong relationships that we have with not only with our patients but with our member services, our physicians, all clinicians, nurses, volunteers, staff, and the community that we serve. We also have 5 basic Sentara commitments, very basic but of the utmost importance to build for our system in quality. And that's that we always keep you safe, always treat you with dignity, respect, and compassion, always listen and respond to you, always keep you informed and involved, and always work together as a team to provide quality health care. Now, the infection control program, next slide, please. The infection control program itself for the Sentara healthcare system has a total of 21 hospital-based infection preventionists. We also have 1 executive medical director, 1 corporate director, a corporate manager, a data analyst. We also have a dedicated infection preventionist for our Sentara medical group, solely based out of the medical offices. And we have 1 dedicated infection preventionist for our long-term care facilities. 16 right now, 16 of our infection preventionists are certified. Some of them have been around a little bit longer than others and have been certified for a couple decades. But one thing Sentara makes clear, and that's that their certification is an expectation. They sponsor and support all of the infection preventionists that come through Sentara to become certified. And if they're new infection preventionists that come on board, they go through a specific orientation and mentoring program that we've developed for Sentara Healthcare Infection Prevention and Control. And the expectation is that they will be certified within 2.5 years. So Sentara is very, very supportive of the infection prevention and control program, facility and corporate-wide. Next slide. So in fact, the Sentara Infection Prevention Program is, I kind of broke it down to 3 different levels. You know, our staff are very well trained and educated, not only in the DMV NIHO standards, but also in the DMV MIR certification standards as well. As I said, we spread all learnings from any survey or any accreditation through our whole system. We have continued education that is facility and corporate supported, and our surveillance is very, very prospective patient-based surveillance. And we'll talk about that a little bit more in a minute. Our surveillance, we have monthly infection prevention and leadership dashboards plus year-to-date data in those monthly dashboards. We also provide monthly and year-to-date unit reports to all of our units. And, of course, we have our reports that we share from NHSN and our work plan updates. The new thing this year for our infection prevention and control program is that we are transitioning to the EPIC Infection Prevention and Control Electronic Surveillance Program. We will go live with EPIC IP in August of this year. And we're very much looking forward to it because the majority of our surveillance to this point has been pretty manual. So we feel like this will help our infection preventionists be able to spend more time out on the floor with our patients and our staff and other healthcare providers while we have the electronic surveillance working for us. Communication. We have a lot of communication, and that's where the prospective patient-based surveillance comes in. We have weekly reports that we report to the whole system. They consist of the previous week's identified Claudia's, CLABSIs, vent-associated pneumonias, MRSA, and CDI healthcare onset cases. It's an electronic line listing that the IPs every Monday have to complete and forward to the corporate analyst that will break it down to our dashboard and our report that is reported out every Monday afternoon or Tuesday morning at the latest. And it supplies, the dashboard supplies the basic information of the healthcare-associated infection in it. We may not have the ACAs or the RCAs completed for those infections, but we do have the basic information and how they meet the NHSN definition. And that is sent out weekly to all of the leadership, and when the HAIs are first identified, all of that information is shared with the unit staff and management, and ACA is begun on any infection identified. We also have weekly issues that we address through tips of the month, safety stories, reminders, and newsletters that we send out. And we have special visits by leadership. We have a lot of rounding that we do, but it's not just infection prevention and control rounding. It's team rounding, EOC rounding, and leadership rounding as well. The special visit leadership rounding, you can see the picture over the right-hand side at the bottom. That is Jennifer Kreiser, our nurse executive at Sentara Lee Hospital. And the leadership is constantly coming up with little ways of identifying how good the staff is working and celebrating every good point that we make. And this was a celebration that Jennifer had identified that we needed to celebrate because one of our hospitals, her hospital, Sentara Lee, was over a year without eclampsia, and they had actually gone 14 months. And so she went out and bought, I think, every Zero chocolate bar that was in the state of Virginia and brought them into Sentara Lee, and we celebrated being zero for 14 months, greater than 12 months that day, because that was the exact date. That was 365 days, and we celebrated it for our facility with all of our staff and healthcare providers. Next slide. We have a culture of safety within Sentara in all parameters of healthcare within our facilities. We also know from the literature as well as our own reviews and deep dives into our healthcare-associated infections, most HAIs are preventable. And that's why we do deep dives, tracking, trending ACAs, and asking the hard questions for every healthcare-associated infection we identify. We know that our patients don't come into our hospitals expecting to get sick, and it really is very hard on the staff when one of our patients is identified as getting sick or developing a healthcare-associated infection. And that's why we developed a lot of safety learnings and safety stories. We have, before every meeting, every committee meeting, any meeting of any sort, we have just a few minutes that we take to talk about a safety story. Lots and lots of infection prevention safety stories where we corrected hazards in the environment, or we prevented transmission of certain diseases, or we identified infectious patients immediately and ensured that there was no transmission of that patient's disease to anyone else. But we also have the hard stories that happen that we identify where we could have done a better job, and we share those stories as well. So there's a lot of communication. Next slide, please. There's a lot of communication within Sentara Healthcare, but for all we do, the question always is, what else can we do? Sentara really has shown significant reduction in our healthcare-associated infections. We're always trialing new products and looking at trends and auditing processes. And what we really do within Sentara is we focus on the basics, but we also believe in innovation and new technology. And we're kind of reaching the limit of human intervention. So what else can we do to be able to help our patients and continuously work on making our environment and our patient health care safer? Next slide. So innovative technology. That's where Cupron came along in their partnership. It was identified by our leadership as being a very innovative technology, and and we really investigated it very hard. But one of the things that the Sentara leadership wanted to make sure that we understood as we joined a partnership with Cupron is that this is a supplement. It's not a replacement for any of our current processes. Our safety processes are our safety processes and must remain in place and must remain at a high standard. But this is a supplement, an additional layer of protection for our patients. And as Dr. Monk said, the hypothesis was surrounding patients with the continuously self-sanitizing surfaces will reduce viral burden, interrupt pathogens transmission, and ultimately help result in lowering our healthcare-associated infections. So we moved forward with this new technology. Next slide. The new technology of Cupron. And as you can see, this is actually pictures of our Cupron rooms. We have the Cupron linen there, as Dr. Monk said, that is a very unique color, which was a very positive to our patients. We had the Cupron horizontal surfaces. We had the bedside table Cuprons, the side rails for the beds. We really utilized Cupron in the highest standard that we could. And what we found was the one thing that we really found interesting was the different color of the linen. It wasn't the regular white, hospital linen. So it really helped us with a lot of discussion with our patients and made it an easier conversion because it was such a nice conversation about the different color. What does that mean? How does that help you? It also helped us educate the community because everything we talked with our patients about, we were in hopes they would go out into the community to their families and their friends and talk about the new technology within Sentara as well. And our patients actually told us into some of the discussions and some of the feedback that they felt safer because we had taken this extra supplemental step within our hospitals. And as one of our infection preventionists at Martha Jefferson said, she stated that we wanted to do everything we can do to prevent infections and that these copper linens and surfaces are just one piece of the infection prevention and control puzzle, but a very good piece because it allowed us to really have great conversations, develop great education for our website, and to go out into the community to talk about this as well. Next slide. Our linen services went from being just a vendor to a partner. They're more important than ever to us. Our linen services are HLAC accredited, which is Healthcare Laundry's accreditation for patient safety. They have been accredited for greater than 9 years. I think it's actually 10 years this year. They process the linen with the same equipment and chemicals. The only change that we made was that the linen was put into a different color bag to collect. And that was only to make it easier on their side to be able to identify the Cupron linen. And then one of the questions, and I think Dr. Monk talked about this too, one of the questions that did come up when we first started with the laundry service was, did the copper transfer to the white linen during the wash process? So we did a lot of laboratory confirmation to demonstrate that the copper did not transfer to the white linen during the washing surface. And again, our accredited linen has to go through accreditation every year, which is a very independent inspection by their accreditation company. And they also have quarterly partnership meetings that infection prevention and control is just one discipline that joins them on a quarterly basis. And every year, one of our infection preventionists does our own inspection of our laundry services as well. Next slide. Every time I talk about laundry services, I always think of this cartoon, which is one of my favorite, about all the curtains that we used to use within our hospitals. Next slide. So in 2017, our trial for Centera was called the expansion trial. This trial was only for the copper linens. We had 6 separate facilities, all with similar patient demographics, none of which had been studied previously, that joined this expansive trial. It was retrospective. We did do pre and post expanded deployment, and it was 10-month time periods for the pre-control time period, which was May through December of 2016, and then the performance or after deployment type period of May through December 2017. Lots of patient days, over 175,000, more than 1,000 beds. And as you can see there, we saw, and the other uniqueness to this, let me just say, the other uniqueness to this trial is that we looked at it at 90 days, 180 days, and 240 days. That was the first time that we had ever made that decision to look at it as an ongoing trial. And you can see that the trial actually demonstrated a 43% drop in C. difficile and a 19% drop in MDROs, which was our VRE, MRSA, and our gram-negative rods. And then we also identified a 37% drop in C. difficile and MDROs combined. Excuse me. Next slide shows that the time period as well as the different hospitals. You can see at the first section, it shows the numbers of incidents and the infection rates for C. difficile alone for each of those time frames, for MDROs alone, and then at the end, the C. difficile and MDROs combined. And you can see the bottom graph is the one that shows just the C. difficile infection rates, where the darker color is 2016, and the lighter color showed the decrease overall for each of those time comparisons. And then the other graph shows the C. difficile and MDRO infections. Great data set set over time with significant decreases. Now, the one thing I will say, and you can probably note there, is that we had very small numbers for C. difficile and MDROs to begin with, but it was we still saw the significant reduction in each of those cases. Next slide. Centera philosophy is that we continuously seek ways to improve patient safety. This technology, again, is a supplement, but it assisted in making our already low rates even lower across multiple hospitals. And I really can't say that enough. You know, I don't want people thinking that this is the one big pitch for how we lowered our infection rates. Again, it was a supplement that assisted us in lowering our infection rates. And, of course, the big win-win of it all was that our patients really liked it, and they talked about it, and they talked about the education that we did before we had it and now that we have it as well, internally as well. So this was a great win-win partnership for Centera with Cupron. The next slide, I can say based on our, I hope the video doesn't automatically start, based on our data and the innovation of this new technology, the Ochsner healthcare system in Louisiana began investigating the use of Cupron, and it was actually after our first Centera trial was published. And I'll let Dr. Monk set up the video for you, but
Brilliant. Thank you so much, Jackie. So I think as Jackie said, you know, we were very excited, and I think it's a very similar story to have another innovative healthcare system in Ochsner working closely with their laundry partner, Crown, to deliver Cupron Medical Textiles. And the video really talks better than I can, so I'll let it just run.
Ochsner Health System is Louisiana's largest nonprofit academic educate, and innovate, coordinated clinical and hospital patient care is provided across the region by Ochsner's 28 owned, managed, and affiliated hospitals and more than 60 health centers. Ochsner employs more than 17,000 employees and over 1,000 physicians in over 90 medical specialties and subspecialties. Ochsner Medical Center in New Orleans is also home to Innovation Ochsner, an innovation center to reimagine and revolutionize the experience and delivery of quality and access, decreases costs, and improves patient satisfaction and engagement, and caregiver efficiency. Dr. Milani, Medical Director of Innovation Ochsner, also serves as Chief Clinical Transformation Officer of Ochsner Health System, is Vice Chairman of the Department of Cardiology, and is a Professor of Medicine at the University of Queensland School of Medicine.
IO is an innovation accelerator, and our mission is to use data and technology to reimagine how we deliver care, but the goal, however, is to optimize outcomes in terms of patient quality and safety, as well as to enhance efficiency for the people that provide care. Optimal hospital is a way of reimagining the experience of care in order to create a safer and higher quality environment for patients as well. We need to find out other ways of trying to not only prevent infections, but treat infections. And it turns out that copper is the only element approved by the Environmental Protection Agency as antimicrobial. So copper has natural antimicrobial properties that actually kill about 99% of all the organisms within contact. So we've aligned ourselves with Cupron as well as Crown, our laundry supplier. What Cupron has done is created some really innovative methods of introducing copper into the hospital environment. They've been able to weave it into textiles, so the sheets and pillowcases that we lie down on. Even the bedside table can now be infused with copper that has these antimicrobial properties.
This Cupron deal was a no-brainer. It was on Crown to decide, can we do this, how do we do this, and just make it happen. With Ochsner having a core value of putting patients first, we're very happy to be involved, and now that we've done our small-scale study and we can run the product well, we're ready to expand it.
So this is a safe and innovative technology that can be introduced into the environment of care that can dramatically impact the outcomes for patients. And the patients really love this, not only because it's soft, obviously, but they see that the extra efforts that we're going through to make sure that they're going to have a good experience during hospitalization.
So I think if the volume was unfortunately low for you, just let us know. The video is actually on YouTube, and we can also send the link out for that so everybody can access that. But I think really wrapping up as we start moving towards the end of the presentation, Cupron Medical Textiles are now used in a number of facilities, all 12 Sentara hospitals, which is over 2,400 beds. Obviously, Ochsner Medical Center, as we've just seen from the video, and more recently, the Children's Hospital of the King's Daughter. Just to make the audience aware, there's really only two conditions that we would say are probably contraindicated for Cupron Medical Textiles. Both of these are very rare genetic conditions that affect copper metabolism, Wilson's disease and Menkes disease. And so these really are the only conditions, just out of an abundance of caution, that we would say that are contraindicated for the Cupron linens. But we're processed daily and multiple. We have over 1.4 million patient days used for with no incidences of safety or any other attributes, really no changes in processes or staff behaviors. And as we've talked about and I think demonstrated with the data set we have, we're durable with no change in laundry processes or chemicals. And so really at this time, we are continuously active. We're complementary as a low-cost option to be added to existing IP programs and practices. With no process changes, we're easy to implement. As Jackie has already talked about beautifully earlier, the color leads to positive patient and healthcare worker interactions. And I think based on our durability and efficacy data, the linens last longer, deliver more servings, and also have efficacy well past the normal life of linens. And I think the data that Jackie has just talked about really now shows that there is really no doubt that the Cupron Medical Textiles can assist in reducing hospital-acquired infections as part of their peer-reviewed and published portfolio. And just as a final image, you can now see the size and scope of the most recent trial that Jackie's just talked about, in terms of our portfolio that we talked about earlier. I think we really couldn't have done this without the partnership with Centera, so I would be remiss if I didn't acknowledge Jackie and all of her colleagues and how much they've assisted us in this process to generate the data and the independent peer-reviewed publication. So I think at this time we would welcome any questions that anybody has.
But I figured that was it. I'll be out in just.
So if anybody has any questions, please use the chat functions. But I think probably just to get us going, some of the questions that we get most frequently asked, Jackie, how was this to deploy? How was your experience with this in terms of deploying it and working with the laundry partner? I know you touched on it earlier, but in terms of actually implementing us.
It was actually a very, very easy. It was actually a very, very easy deployment. Again, we have a public relations department that did a great job of getting the information out to the community. And then we had a lot of support for our nursing staff and our units for coming up and educating the patients if they had any other questions about the products or what it meant to them. And, of course, the nurses were and the ESD people were very well trained in these products so that even if an ESD worker walked into a room and a patient asked, the ESD worker knew everything about the products as well, very well trained throughout our system. So it really turned out to be a fairly easy conversion. The only thing, and Dr. Monk knows I've said this before, the only issue that we did have to address was the bringing in of new products, such as, bedside tables. You really have to educate the partners that bring in the new product on what your process is for taking out the old, again, say bedside table and putting in the new one. They have to be reminded and educated on hand hygiene, on wiping down the old before bringing it out to the hallway, wiping down the new before taking it into the patient room, and make sure that they follow your processes for your facility. And so we ended up developing a job aid to cover those issues and some education. But that was the only thing that slowed us down just a little bit at first. But again, the conversion and the products are so well loved. It's been really great.
Well, thank you for that, Jackie. And right now, if anybody has any questions, it's probably as we start closing out. If anybody has anything else they'd like to ask, please feel free to do so now. If not, I'll give it a minute or two. But, any other comments from you, Jackie, that you'd like to make about this? I know from our end, really, we just, again, really can't thank Centera's infection preventionists, both current and prior, for all of their help and support with this. And also thank the audience for joining us today as we wait to see if there are any questions coming in. Jackie, anything in closing you'd like to add?
No, and I'd like to again say it really was the work of the Centera infection preventionist, and that's why we recognize them at the end with this slide. If it wasn't for their hard work in collecting the data or supplying the data for us to be able to work through and analyze, we probably wouldn't have been able to do this. So they worked very hard, and I appreciate every single one of them.
And that's great. So I think with this, I will thank again the audience for joining us today. Please contact Cupron or Sharon Oakley, who issued the invitations. If any of your colleagues were unable to attend today, we'd be delighted to repeat this for them. If anybody would like a copy of the slides or any further information, again, please feel free to contact Sharon Oakley or Cupron. And with that, I will say thank you very much for joining us today.
Thank you, Dr. Monk. I appreciate it, and thank you, everybody, for attending.